lecture. I am very excited to be here because this is the very first time that we are giving this first part of the lecture called the primary care system in disasters. This is a pretty novel topic, and I'm curious and looking forward to receiving your feedback at the end of the lecture. Last year, I gave a lecture on vulnerability, and this is going to be the second part of this talk. The very first part, I just wanted to introduce you with the concept of what is the involvement of the primary care system in disasters. My name is Alessandro Lamberti Castronuovo. Stefania already introduced me. I'm a medical doctor. I'm an emergency physician here in Northern Italy. I hold a Master of Science in International Health from the Charité University in Berlin, and also I'm here as a PhD candidate at the last year of the PhD program here in Novara at UPO. And as you might imagine, the topic of my PhD program and dissertation is how do you improve care delivery, healthcare delivery to vulnerable populations during disasters. And as we will see, the best way to do it is through the primary care system. So the topics, as I said, that we're going to touch on today is how and in which ways the primary care system can be involved in disasters. And as I said, the second part is going to touch on the vulnerability aspects, sorry, during disaster medicine. We're going to go about one case study, and we're going to draw a conclusion all together. But before we start, I just want to please know who I'm talking to. I just want to have a couple of sentences with who you are, where do you come from, what your background is, and what your understanding of the term primary healthcare is, and especially how the primary care system is conceived in your country. Because as we will learn, the primary care system is intended and structured in different ways in different countries. So let's start by Victor. The first person I can see here on the screen. Victor, can you hear me? Okay, let's move to Roxana. Is anyone here, guys? Is this an interactive lecture that you want to have, or?
Yeah.
Hello. So who's starting?
Hello, I'm Winston.
Hi, Winston.
Should I introduce myself?
Sure. Yeah.
So hi, Alessandro. I'm Winston from AMSA Hong Kong. So from Hong Kong in China, yeah. And I'm a first-year medical student of the University of Hong Kong. And my background is it's my first year as a local officer of human rights and peace within the IFMSA structure. And I was really interested in disaster medicine and how to manage primary healthcare in that kind of situation because of what I learned from like my own experience and things I've heard and researched into about various different disasters and how, for example, in our different cities, how we can cope and how the future looks for an ever-changing world with climate change and all that kind of modernizing developments. And yeah, in my understanding of primary healthcare, I suppose it's just the frontline workers that really take in any disaster or triage or anything from the first line, and they just start off and are really one of the most important, like I guess, frontline defense that manage and deal with all of the first primary implications and management for patients.
Sure, brilliant. Thank you so much, Winston.
Thank you.
Yeah, so is there anyone else who wants to introduce himself or herself?
Hi, can you hear me?
Yes, sure.
Yeah, so my name is Jia Xing. I'm originally from Singapore, but I'm now a medical student studying in the UK. And so my understanding of primary healthcare is quite basic because I haven't gone to my clinical years yet. So I guess we did have some GP attachments. I think general practice is a big part of primary healthcare here in the UK. And obviously, like, primary healthcare is the first line support for patients, I guess. And before they can be even like transferred to secondary or tertiary healthcare. And therefore, I think it's very important, as Winston said, like, as the first response.
Yeah, exactly. Thank you, Siki. Do we have other people who are willing to talk?
Hello, my name is Laura.
Hi, Laura.
I'm
Please go
from
ahead.
I'm from Romania. I've been a volunteer for. I've been an EMS for a year and a half, and here in Romania, the primary care system is a little bit lacking. We have family doctors. We who kind of have to take care of their patients, but many people come to the emergency room without seeing their primary care doctor, and it's just chaotic.
Yeah, I guess. Thank you so much, Laura.
Yeah.
Thank you so much. Do we have other people here? Otherwise, I can start, so we won't waste any.
Yes.
Yeah, who is it?
Yes. Hello, I'm Inas Osama from Medicine Sudan. What's my background? Primary healthcare is, as they said, the first line. It's like, how can I say it? It's like achieving the healthcare, the necessity healthcare that is needed for the people, physical, mental, etc. In Sudan, because most of people live in poverty. There are difficulties of them to attain this healthcare, and yeah, that's it.
Thank you so much. Thank you so much, Inas. Okay, so I'll start, and then if there's there are other people that want to introduce themselves, please just stop me while I'm talking. But I just want to go and get a start on my talk today. I just want to start by saying we as researchers, whenever we have different topic that we want to tackle, that we want to deal with, we start by looking at frameworks. And for us, disaster medicine researchers, when we want to have an overview and an understanding of what disaster risk reduction is, we go and have a look at all these frameworks that you see, whose logos you see here: the Sendai framework, the SDGs, the international health regulations, the Paris Climate Agreement, and all of these frameworks, they give us an understanding, and they build awareness on disaster risk reduction, because our aim is to ultimately reduce the risks to disasters, to help communities to be more prepared for disasters. And I'm sure you've heard this expression before, to build back better. So in the phases of recovery, rehabilitation, and reconstruction, I need to rebuild the health system in a way that is stronger than before. And for those of us who deal with disaster risk reduction from a health point of view, we refer to the Health Emergency and Disaster Risk Management Framework. And this is a very important referral document for us, because it sets guidelines to reduce health risks and consequences of emergencies. It gives us a systemic approach. So it focuses on health, but from different points of view: how the health sector, hospitals, primary care system, emergency medical services should behave and act, in terms of preparedness for disasters and in terms of response to disasters, but also considering other aspects like financial aspects. Where is all the money coming from for disasters? All the legal aspects. Think, for example, of about the migrants who come to a new country in the middle of a disaster or just after a disaster, and we need to take into consideration all the legal entitlement aspects that during the disaster, or communication. How do I communicate the risks for this disaster to the population, especially to the vulnerable population ones? So it sets a common language, a comprehensive approach for all actors involved. Why am I saying this? Because all these inspiring principles are based on this framework being a comprehensive, inclusive, multi-sectoral, but the aim of this document is to improve the coordination among all sectors, among all health sectors and the other non-health sectors, building ultimately community resilience. And the effective implementation of all these rules that are contained in this framework will be critical to achieve the universal health coverage, following the motto, leaving no one behind. And if you open the pages of this framework, you will see that there are different pillars. There are health-specific pillars, like human resources. Who are the human resources involved, that should be involved in the response to disasters or in the preparedness phase? Are we talking about hospital workers? Okay, but what are also the primary healthcare workers supposed to do in the preparedness phase of a disaster or during a response? What are the planning for staffing requirements? What is the proper education and training that they need to have in order to be able to respond to a disaster? Or, for example, there's the chapter on health infrastructure and logistics, or the chapter on health services and community capacities. And if you open this framework, you will see that the framework talks about strengthening health system, so strengthening the response to disasters or strengthening the preparedness for disasters. And it says underlying, I'm sorry for ambulances, underlying the concept that especially at the primary healthcare level, community capacities must be strengthened and the health system must be strengthened. Or there are other chapters that refer to non-health specific pillars that also talk about the way that the health sector should liaise with other sectors at each level. So if you open this theoretical framework, you will ask yourself, well, of course, primary healthcare system is a part of the health system, so it should be able to be prepared for disasters and it should be able to respond to disasters. So if you close your eyes and think about the response to a disaster that can happen anywhere, that can happen in Sudan, in Romania, in Hong Kong. You talked to Marta. Marta gave a lecture yesterday on triage. So I'm sure that you guys are experts on triage right now. So if you imagine that there's a disaster happening, I think the most common thinking is to associate disasters to hospitals, because when we think about disasters, we think about earthquakes, a lot of casualties, a lot of wounded, and a lot of people that need hospital management. So we need the triage to rapidly evaluate patients, and especially to establish what the most appropriate level of care and treatment for them is in light of the scarce availability of resources. And connected to the concept of triage is the surge capacity. So hospitals need to accept and admit patients rapidly, but also at the same time to rapidly expand and augment services in response to the incident and to manage patients who require to be hospitalized. So my question is, given the fact that most of you, or at least most of the people who talked, gave a very on-point definition of primary care. My question is, what do you think that the role for lower levels of care, like the primary healthcare systems in disasters, can be? So if there is one, what do you think that the role for primary care system could be? So just think of, for example, the Zeking's GP in UK, or the family doctor of Inas in Sudan. How can they be prepared, or how can they respond to disasters? And as I said before, this is a completely very new topic in disaster medicine, because up until, I would say, 10 years ago, I'm sorry, everyone was thinking, all of the research were thinking, sorry, I need to drink some water. All the researchers were thinking that disaster medicine equaled hospital medicine, or at least emergency medical services like ambulances and stuff. But then the question was, what happens to the other patients who don't need specifically services from the hospitals, and what happens to those patients who have nothing to do with the disasters but still need to access health services? And just to give you a little bit of background, I want to talk about what the functions of a primary healthcare system are in peacetime. So when we're not talking about disasters, we're talking about normal GPs, normal family doctors, normal primary healthcare physicians. There are 4 core functions of the primary care system. As many of you said, it is the first contact. And this is exactly what it is. The primary care system is the first point of entry for many of us, for many individuals, when necessary, especially for marginalized communities, for vulnerable categories. It usually offers comprehensive care. What does it mean? It means that it offers health promotion, health prevention, treatment, and rehabilitation appropriate to the primary healthcare context. Let's think of, for example, chronic diseases like diabetes or arterial hypertension, high blood pressure. These are all chronic diseases, the so-called non-communicable diseases, and the setting of the primary healthcare is the right setting where to deal and manage these conditions. There's a coordination. So all the care that an individual receives at the primary care level needs to be coordinated. So if I'm a patient, for example, with diabetes, and I have a chronic disease, I'm managed by my GP, and everything's going smoothly. But then something happens. I get an infection, for example. And so my sugar levels are super high, they're sky high, and I get some complications from the diabetes. I need to be then referred to a specialist doctor or to a hospital, for example, if the infection is pretty serious. And so ideally, the primary care system needs to be coordinated with the hospital that is admitting the patients. Because when the patient, for example, will be discharged, when I'm getting discharged from the hospital, I need to return back to my primary care physicians, who needs to be informed about what had happened, what I had received as medications. And so this means integration of the primary care systems with other parts of the health systems. And then continuity. And continuity of care is a concept of paramount importance here, especially in disaster medicine. Why am I talking about continuity? There needs to be a temporal relationship. So there needs to be a mutual trust between me and my patients, between me and the families and the communities where my patients live. So all the services that are offered at the primary care level are different in terms of, in relation to the country I am in. In Italy, for example, the primary care system should give or manage health promotion activities, health prevention activities, free rehabilitation, for example, after a stroke or after an incident, care, as I said before, care for chronic diseases, proper recognition of the worsening, as I said before, the complication, for example, of diabetes, is very important maternal and child health care, and the referral, as we said, to other more specialized levels of care. So, having said that, what do you think that the roles and functions of the primary healthcare system during disasters can be? Do you see it more in the preparedness phase? Do you see more in the response? Do you see it more in the recovery or mitigation? As I said, we're talking about something that I'm doing my PhD program in, and it's a very novel topic, novel aspect. So there are no wrong answers. There are all right answers. And I just want to hear from you if you have some ideas of imagining, just imagine GPs, your family doctor, in the aftermath of a disaster or just preparing for a disaster. What do you think that their role can be should a disaster happen in your context? Just imagine and give me an answer. Who wants to intervene?
So I think, sorry.
Someone raised a hand. Someone was talking.
Yeah, so I think like one of the possible roles that they could play would definitely be like helping victims who may not be severely injured, but like maybe affected in terms of mental health, or helping them to go back to like normal life after a disaster.
Brilliant. Yeah. Who was it? Was it Zekin?
Yeah.
Yeah, sorry. I have troubles associating names to voices. Okay, Winston had a contribution also.
Yeah, I 100% agree with Zheqing's point. That's definitely a very important point to talk about for the mental health aspect side of things. I was also thinking when you mentioned the preparation for disasters, perhaps things like stocking up medications or resources and like stock taking to make sure that primary healthcare facilities are able to withstand any common disasters and some more, such that they are ready to, pretty much ready for anything.
Yeah, brilliant. Thank you, Winston. Are there any other comments? I'll just give you 30 seconds. I need to turn my aircon on. Just one sec. So here I am. Are there any other comments, or should I continue? Hope you're not sleeping, guys. So, as Winston and Zeking had brilliantly anticipated, there are many functions that the scientific evidence or the disaster-related literature pinpoints for the primary healthcare role in disasters. And the first one, you have to imagine, because we said that the primary care system is the first point of entry, it should also be the first point of entry, at least the closest point or the closest health service that is actually in the community when the community is hit by the disaster. So physically, logistically, due to the proximity of the primary care centers to the community, they're likely to be the first responders and also the first point of entry for the marginalized communities. Consider an earthquake that destroys the area. It might as well be that the primary care facilities are destroyed, as well as hospitals and stuff, but you have to imagine that when an earthquake, for example, happens, the community, the district where the earthquake is happening will be very difficult to be reached by external aids. So primary care physicians, primary care infrastructure, pharmacies, or local small NGOs, these are the first point of entries because they're logistically placed in the same district and in the same physical space as the community they serve and the communities that's hit by the disasters. So just for logistical reasons, they're usually the first point of entry. But as Zekin also had already said, it could also be useful for managing cases at the primary care level when the cases are less serious. So not all the cases should go to the hospital. Hospitals, especially secondary and tertiary level hospitals, need to be ready to deal with, of course, more serious cases. And all the less serious cases should be then devolved and sent and referred to other and lower levels of care, and then so the primary care level enters. And then we're talking about continuity earlier on, and continuity of care, it goes without saying, I guess, continuity of care is a concept, a very important concept in disasters, especially for people who need to access services, primary care services during disasters. So primary care facilities, according to the framework that we were referring to, needs to be present and open all the time, and needs to be able to guarantee continuity of care during disasters for non-disaster victims and for example, disaster victims that are less serious cases. And then patient-centered care. So the beauty of the primary care system, the beauty of general practitioner, primary care nurses, social assistants, psychologists, this is all the workforce that constitutes the primary care facility. They understand, or they should at least understand, what the social determinants of health are. So the environmental, the social, the cultural aspects that are important for the health of the individuals. And GPs, primary care physicians, should then be able to understand not just the disease, but the social determinants of health that had contributed to this disease. They should be able to deliver a context-appropriate care. They should be able to do risk communication. What does it mean? If I'm preparing, if I know that a disaster will be, sorry. If I know that a disaster is going to take place, or if I'm just about in the aftermath of the disaster, I need to talk to people. I need, for example, let's make an example. During COVID-19, what about all the rules of don't overcrowd, social distancing, wear the mask when you're in public places, lockdown, or things like that? You need to be able to deliver all this information in the language that the patient is speaking, so, and respecting or delivering a context-appropriate care, meaning I need to be able to make sure that the patient, whatever cultural background he or she has, understands what I'm saying, understand the risk of what it means not wearing a mask, not abiding by the rules of lockdown and things like that. So risk communication is a huge, it has a huge importance in primary care disaster management. And also continuing work with the communities through the emergency into the following phases. Another very important function of the primary care system is the public health function. So because they're so close to the community, because they have this special relationship to the community, because the primary care physicians should know your medical history and your family history by heart. They should play this important role of notification, disease surveillance, immunization. Again, COVID-19 sets an example here. So, and this is, for at least in Italy, this is exactly the opposite of what happened in reality. So what the framework is saying is that the primary care network should be able to follow, manage, notify, or even perform vaccinations during a pandemic. And this is, for example, what happened in Italy was completely opposite. So there was a new service that was created instead of the primary care system to grant continuity of care specifically for COVID patients. And this is not what the primary care, a country should respond to a disaster. So the primary care system should have in itself the ability to deal with these public health functions during a disaster. And then I believe the most important thing is the proactive engagement and the appropriate communication with communities, as we just said, needing with the objective of empowering especially marginalized communities. Think about rural communities, for example, geographically marginalized communities in the middle of a disaster. Who should they turn themselves into? Who should they talk to? They should talk to primary care network, who is, as I said, physically there to help and assist. And another very important concept that I believe that we have touched on already is that the primary care system is able to respond during a disaster, not just to the primary surge. What is a primary surge? As you can see here from this graph, here is the disaster, and when a disaster hits, then there's an acute response phase 1. Acute response phase 1 means just exactly what we've said so far. Lots of casualties, lots of people who need care, who needs to be triaged and referred to hospitals. But there are, and this is the primary surge, but within this primary surge, there are patients that won't need just hospital care because they're not so severely impacted by the disaster. And the primary care system can be open, it should be open to assist these patients. But then there's another part that I believe is equally interesting and important, which is the so-called secondary surge. What is this secondary surge? And as you can see, here is expressed time. When the disaster hits, just about 96 hours after the disaster, we can talk about the acute response. And so hospitals are impacted within the first 96 hours in such an important and relevant way. But look what's happening here. We're talking about years. So the secondary surge is something that happens just immediately after the disaster and can extend itself for weeks, months, and even years after the disaster. But what is it? It's the so-called primary care needs. So all those needs that are not specifically related to disaster, but that they are, though, impacted by the disruption of care caused by the disaster. I'll make an example and you'll understand immediately. Let's talk, and we did this example, I guess Winston had already talked about this. Let's talk about our diabetic patient, and let's talk about the fact that he needs insulin, he needs anti-diabetic medications, he needs continuity of care, because even though the disaster had struck, he needs his medication, he needs his stock, he needs his prescriptions, he needs his refill of medications. And so there's a a large body of evidence that talks about the secondary surge in terms of all these patients who have chronic diseases, who are impacted by the disaster, because if the hospital or primary healthcare do not function anymore, so the disruption of care happens, then they will have needs that need to be tackled with, need to be dealt with at the primary healthcare level. So all the medications, for example, that they need, or we were talking about mental health. Within the secondary surge, also the mental health is included. Let's think about, again, COVID-19 and the surge in mental health cases and psychological needs that all the patients and individuals had after lockdown, after the pandemics, after the disaster that happened. So this is the secondary surge. The needs that individuals have, mental health needs, chronic disease needs, pharmaceuticals or drugs availability needs that are not directly connected to the disaster because they're not caused by the disaster directly. It's not a broken bone, but they are connected to the disruption of care that the disaster had caused. This is a very important point. I'm going to touch on this topic on the chapter of vulnerability, but this is a very important point that I really want you to focus on. It's a very interesting concept, and I think that's very useful if you guys are interested into disaster medicine. If any of you has questions, please interrupt me and just or raise your hands, do whatever you want, but just talk to me. So just in conclusion, what I wanted to convey with this first presentation is that what we're trying to do is just consider that there are parts of the health system, like the primary healthcare system, that has been historically neglected or disregarded in disaster medicine, but must play an important role in any phase of the disaster, during preparedness. Because if, as Winston was saying, if, for example, I know that I have that 30% of my patients are diabetic patients, I need to be prepared. If I know that my country, that my context, that my community is prone to disasters, is prone to earthquakes, for example, I need to be prepared for guaranteeing that my patients get continuity of adequate care that they deserve. So what I'm trying to do, what Crimedim is trying to do, but fortunately many other research groups are trying to do, is to incorporate elements of disaster preparedness, disaster risk reduction within the care delivery that the primary care system normally does in peace times. And as we said before, guaranteeing basic health services, guaranteeing disease prevention, health promotion, patient education, proactive engagement of patients, care for non-communicable diseases, trying to reach especially vulnerable communities like isolated communities, geographically marginalized communities, elderly population, migrants, chronic patients, people with mental health problems, but also healthy individuals, because we were talking about disease prevention. And so this is also a very important function of the primary care system. Well, as I said, what I'm trying to do now is within my project to assess what elements are necessary for a primary care system to be prepared for disasters. And what I'm doing is a literature review at the primary care level, but I also want to see what happens at the community level. So seeing from the perspective of patients and individuals, for example, NGOs must have an important role in responding to disasters when in their community. or community representatives or patients and households, how do they prepare for disasters, and what are the elements that they need to have to be prepared for disasters? And this is the last slide, but I just want to give you an overview of this new concept of primary healthcare disaster preparedness. What I did was, through a literature review, identify the specific factors that render a primary care system prepared for disasters. And I came out with a framework that I then categorized according to the 6 WHO building blocks. I'm sure you've already heard of them. So these red boxes are the 6 WHO building blocks. So I didn't invent anything here. Leadership and governance, service delivery, health information, workforce, medical products, and financing. And according to the 6 WHO building blocks, I then categorized what I found in the literature that was referring to primary care disaster preparedness. And as I said before, I didn't find many articles, but what I found was, to me, was very interesting. So what the literature says about it is there needs to be policies and laws and regulations that specifically address how the primary care system can integrate within the health system of a country, within the health system of a region. How can it integrate with the other systems? So how can, for example, the primary care system can integrate its functions with the hospitals should a disaster happen? So there needs to be plans, written plans on how this can integrate and interact with the hospitals. As I said, again, continuity of care. So if an earthquake happens, well, for example, I need to take into account the possibility that the primary care facilities can, as we said at the beginning, can be completely destroyed. So I need to have plans well ahead the disaster, plans that take into account possibilities of alternative places. Where would I see my patients if the disaster happens and my facility gets completely destroyed? So do I have memorandum of understandings or agreements with transportation services? I can have a mobile clinic, for example. Or will my opening hours of my facility, are they known by the patient? Do the patients know when I open my facility, or should I extend the opening hours of my facility because I expect after a disaster that many patients will come to me? So I cannot just be open for 2 hours as usual. I need to extend the opening hours to let more patients come in and to let every patient have his or her adequate care. I need to integrate many different services. If I'm a GP, I might not see broken like wounds or broken bones or minor issues, minor health issues that are disaster related. So I need to integrate in my knowledge and with the training, even disaster medicine aspects or disaster medicine things that I need to know to be able to assist my patients. I need to engage my community. The community needs to be prepared as well as the facility, and the patient and household preparedness need to be prepared. For example, I need to tell my patients, my diabetic patients, that if a disaster comes, if an earthquake comes, he or she needs to have a stock of medication or a so-called go bag, like a bag that they would then use with their, for example, medical history or a medical summary, or a list of the allergies that these people have, because they might find themselves in a completely different context, in a completely different situation, with completely different health professionals that do not know their history. And as we move along in the framework vulnerability assessment, I need to know as a primary care physician who the most vulnerable in my communities are. Let's think, for example, of bedridden people. If an earthquake happens, who's going to save, who's going to rescue these people that are bedridden or disabled people? So you have to think, not only think, but then act, because you need to prepare the patients according to their levels of vulnerability. And you need to have a so-called incident response plan. So for example, what happens if I am in the middle of my opening hours in a peacetime, I'm very relaxed, I'm seeing my patients, and an earthquake happens? What am I going to do? You know, so who am I going to call? So the incident response plan, like the hospital has its response plan, a primary care network needs to have its response plan. The team needs to be multidisciplinary. Some of you were talking about mental health issues. I'm a primary care physician, so I cannot be, I can, to a certain extent, be in charge of dealing with psychological problems. But what if in my team, I have nurses, psychologists, social workers, community health workers? So this needs to be taken into account. Of course, according to the context and to the people you are dealing with, to your patient community, surge capacity. So you need to be able to have more people. If you need more people, imagine after an earthquake that 30 people stand at your door. So you need to be able to surge in terms of stuff, in terms of people, in terms of stuff. So in terms of, for example, the medications that you need to have in stock, and in terms of systems. So who can I call to assist, to support my facility if I need more people? Are there any volunteers? Are there any other doctors that can help me? Are there any nurses that can help me? So this needs to be very precisely structured before, of course, the disaster happens. Training and education. That goes without saying that training is important for primary care physicians, especially because they're not used to deal with emergency medicine. I'm an emergency physician, but I'm also a primary care physician, so I'm lucky, but not, but because I like both aspects of this, the health system. But what if you like chronic diseases and you have never been confronted with, I don't know, broken bones? Safety and protection of workers, of course, it's very important to overcome stress, but also to be prepared for the acute impact and stress that disaster can have on my colleagues, on myself. So I need to be, let's not talk about also, you know, PPE and that part of occupational health that is also important. So physical and mental safety and mental protection. I need to have adequate medical and lab equipment. I need to have the appropriate infrastructure and technology, and also I need to have money. So there should be a financing, a money allocation that I can use as a primary care physician, as a primary care facility that are usually, at least here in Italy, they are regulated at a regional level, that can be used as a budget for emergencies. What am I going to do now with this? We're going to do then an assessment tool, as you can see here, because from this framework, we're going to extract or derive an assessment tool to check the level of preparedness of our primary care facilities in Italy. We're thinking of developing a curriculum for training courses for primary care professionals at the WHO. And of course, this can be, as I said, this is a novel topic. So there are very few studies on the topic. So this could be, you know, the background to for further studies. I'm gonna just give you a 2-minute break, and then I want to start on the second part of the lecture, which is on vulnerability. and there's going to be a case study on vulnerability in disasters. So I'm hoping that you'll be more awake by then. Just 2 minutes of break, and I'll start in 2 minutes again. If there are any questions on the presentation that I've done so far, please ask. Was everything clear? Did you understand everything? Are you still there? Okay.
Yep, all good. Yep.
Cool. Okay, so then just 2 minutes. So, are you guys ready?
Yep, sounds good.
Okay. So, this second part of the presentation of the lecture is something that's very close to my heart. This is how I started. My background is, as I said, emergency physician. I've been working with NGOs for basically all my career, and I then switched from NGOs to the academic work, but still as a sort of liaising between NGO world and research institutions, academic institutions. And so to me, vulnerability in disasters is a very interesting concept, and the concept that I'm basically on my career on. And so I'm expecting you to get all the nuances and elements, interesting elements that that this topic has. When we talk about vulnerability, we don't have a single universal and commonly agreed definition. We can refer to vulnerability as the susceptibility to suffer damage in a dangerous event, whether it be natural, economic, or political. if you look at the definition that the UN Department of Humanitarian Affairs has, is the degree of economic loss resulting from a damaging phenomenon. But if you look at what engineers say, of course, they're going to talk about the fragility of built structures. So what we as health researchers in disaster medicine think of is the vulnerability of people. And so the characteristics that a person or a group or a community has in terms of their capacity to anticipate, to cope with, to resist and recover from extreme natural events. So why is it important to define vulnerability in disaster medicine? Because if I assess vulnerability, and if by assessing vulnerability, I also assess the capacity that the communities has to respond and to resist, so the so-called resilience of the communities, if I assess all of that, this is critical to determine how I can then intervene to reduce the disaster risk. I mean, this is pretty obvious, and how then to foster the community resilience. So that's why it's important. And so when we're talking about vulnerability, we're talking about different types of vulnerability according to the perspective from which you're seeing the whole thing. You can talk about physical vulnerability. So when human beings or infrastructure have inadequate characteristics that or inadequate resistance to a hazard. We can talk about economic vulnerability when we're talking about, for example, financial hindrances or financial difficulties that that people have. Political vulnerability, as for example, in a specific context, having little or no political power, representation, or autonomy. We can talk about social vulnerability when there are, for example, formal institutional structures that marginalize certain groups based on their socioeconomic characteristics, for example, like gender, race, or ethnicity. Or you can talk about social vulnerability when you consider just the social relations that a person or a group can have with friends or families. Or psychological, when the mental characteristics, when we're talking about mental characteristics that influence coping skills with disaster stress and the likelihood of experiencing an emotional injury or distress, or even the environmental vulnerability, which is the tendency of the environment to respond to changes in human and climatic conditions, either positively or negatively. So when you think about the most, now we're back to disaster medicine. So when we're thinking about vulnerability to disasters, we're thinking about people that are usually the most marginalized sections of society. And this can be for different reasons. We were talking about rural communities, geographically marginalized people, or we can talk about members of minority groups or disadvantaged ethnic groups in a country or in a context. We can talk about economically fragile people or people who lack political power. And there's this new, very trendy, fancy word of intersectionality, but I think it's a very, very important concept when you think that usually the geographically marginalized people are also those who are economically fragile, or members of minority or disadvantaged ethnic or social groups are usually those who do not hold political power. And so we talk about intersectionality. And these aspects, so intersectionality means basically that these aspects can combine together, bringing about a greater level of marginalization, vulnerability, discrimination. So as you might have understood, but I'm sure that you guys knew it before, vulnerability is determined by a variety of intersecting and perpetuating structural conditions. It's a function of limited access to resources and power. Think about irregular migrants in the host country. Think about the limited access to resources that they have. For example, limited access to healthcare. And the vulnerability presents in and arises from the social and economic circumstances of everyday living. So, and this is the most important concept, disaster do not discriminate on people. They have an effect on the community that is not just random. It's determined by everyday patterns of social organization, of social interaction, but this complex stratification paradigm that determines access to resources. What does it mean in vulnerability in disaster medicine? The conditions determined by human, economic, and environmental factors or processes that increase the susceptibility of individual, community, or assets or systems to the impacts of disasters. And here you can see a list of all the factors that can contribute to increasing the susceptibility of people, of community, of systems to the impact of hazards. So as I just said, disasters do not discriminate. They do not select victims based on their ethnicity, based on their gender, based on their class. They strike on people with the same intensity. What is it then that renders people vulnerable to the effect, more vulnerable, more susceptible to the effects of a disaster? The consequences of a disaster, in fact, are not the same for everyone. And some categories of individuals are more negatively impacted by disasters. This is vulnerability to disasters. And so we're talking about all those conditions determined by physical, social, economic, and environmental factors that increase the susceptibility of these individuals or these populations to the negative impacts of a disaster. So the consequences of a disaster replicate or exacerbate the effects of inequalities that are existing prior to the disaster, impacting more the marginalized and socially disadvantaged individuals. That, until now, was the theory, and the theory is pretty simple. And the reason why I'm saying all of this is that we need to study, we need to take into consideration vulnerability in disaster medicine. As I said, certain categories in the population are disproportionately affected. And remember that this vulnerability can manifest itself in every phase of the disaster cycle. For example, vulnerable categories of people can be those who are unable to prepare adequately, or, for example, may not receive adequate support to recover from disasters and disruptive events, or they are less able to care. Let's think about, we were talking about before, about the bedridden individuals in the middle of an earthquake, less able to care for themselves during disasters. Or, for example, and here I'm referring to the diabetic patients that we were talking before, they are least resilient to the service disruptions that typically accompany disasters. Think about our insulin that the diabetic patient needs to receive during disasters. What happens if the migrant, for example, if the homeless person or if the poor person does not have access to these medications because lacks, for example, because he lacks entitlement to access the national health system, as it happens in the States, for example. So we need to take into consideration all these factors. And as I said, it can happen in any phase of the disaster because the vulnerable individuals might not know they should have preparedness supplies, so they do not have the necessary information, or they are unable to be prepared, like the bedridden individuals in the middle of an earthquake, or because they have fewer connections to neighbors and community, so they have less resilience and less ability to seek support. And so they have increased risk of injury, illness, and exacerbation. So understanding what these factors that lead to vulnerability are in a community is very important for disaster researchers, for disaster managers, for people who work within a health system, like, for example, primary care physicians or hospital professionals. It is very important to assess these factors of vulnerability during disasters, because it will lead to a more effective management of disasters, because it will help me allocate resources and interventions, especially or primarily to those people who I believe are more vulnerable, or to those communities that I believe are more vulnerable than others. And trying with the ultimate goal of resolving, tackling social and geographical inequalities of resource distribution. So how do we do that then? Let's get practical. How do we assess vulnerability in disaster medicine? I need to focus on three different aspects of this vulnerability. I need to focus on the human vulnerability. So poverty, marginalization, conflicts, social networks within a community. I need to focus on the context. So what is the health system of that country, the land use, the territorial planning? What is the use of natural resources? What is the people getting their sustainment, their sustainability from? And economic. So at the end of the day, it's the inequitable distribution of costs and benefits, or poverty at the end of the day. And so at the beginning of the 2000s, we were thinking that vulnerability was just the estimation of deficiencies. So you're vulnerable because you're poor, you're vulnerable because you're not a man, you're vulnerable because you're this ethnicity instead of that other. Whereas now, the assessment of vulnerability is more a multidimensional concept. So now is more focusing not just on what is lacking or what an individual is lacking, but also what their capacities are to resist to the shocks of disaster. And also, what are the potential interventions that a primary care system, a NGO, a hospital, or a system, a government can put in place to reduce these vulnerability factors. So not just people's economic losses, but physical, economic, social, and environmental. So again, two different concepts here. Vulnerability is not just the estimation of deficiencies, but also focusing on coping capacities and potential interventions, and not just focusing on losses, so economic losses or just mortality, but also I need to focus on what are the impacts of disaster on the physical, on the economy, or on the social aspects, or on the environmental aspects. And another very important factor to understand is that according to the type of disaster I'm talking about, I need to take into account that the vulnerabilities can be also different. Look at these images, earthquakes, compared to war or drought or hemorrhagic fevers or pandemics or heat waves. So as you might have already heard from my colleagues, there are two different types of disasters. They're rapid onset, they're slow onset. So if an earthquake happens, it's a sudden onset disaster. So I expect that the economic vulnerability should focus on the short-term disruption that the earthquake had caused. And the health conditions, the consequent health conditions of this sudden onset disaster, there will be, of course, more trauma-related issues, at least in those 96 hours that we are considering. When we're considering slow onset, like pandemic, you know, COVID is still happening, and it started two years almost, beginning of 2020. So the health conditions that I need to focus on are not, of course, just the COVID-related respiratory infections, but also at the I need to focus on the secondary surge. So almost also chronic issues, and the economic consequences, of course, are going to be totally different, because I need to consider also the flexibility of the economy to adjust to more prolonged disaster situations. And again, here I'm talking about the same thing. So this is the graph, the chart that we saw already. So always consider that the vulnerable individuals are not just those that you will see in the first 96 hours of the disasters, but you will see consequences. Think about the mental health consequences of COVID or any other sort of disaster that you will able to capture even years after the disaster. And so when you assess the vulnerability in disaster medicine, you have this nice mathematical formula that just tells you again what I've been repeating in the last 20 minutes, that has specific hazards like natural hazards, biological hazards. They do not affect all individuals, households, communities, and infrastructures to the same degree and in the same way. So the potential risk, so the potential disaster losses equals the type of hazard, the intensity of hazard, but also the exposure, the vulnerability, but it's also inversely related to capacity. So the more capacity the community or the individual shows, the less the risk. So it's also called absorptive capacity, because it enables individuals or communities to absorb the impact of a disaster to a certain extent, to a certain degree. But then here there were two terms. You know, we've talked about vulnerability, but exposure is something new. And just to make you understand, to let you understand the difference between vulnerability and exposure, there's this nice drawing here, which will enlighten you and make you understand the difference between exposure and vulnerability in 2 seconds. If this is a flood zone, you know, a flood prone zone, and here these are houses, you know, there's a house here, nicely built house located outside the floodplain. There's this other here in sort of midway, located at the periphery of the floodplain. And there are 2 other houses that are located on the floodplain. Of course, this is the exposure. You know, of course, these 2 houses are more exposed than this other house here. But can some of you guess what vulnerability then is? I mean, it's written, so you don't have to guess, but can you just verbalize? Can you just verbalize it?
Perhaps any of the predisposing factors that I guess
you are the only student here today.
Sorry, let me gather my thoughts. The predisposing factors that ultimately, I guess, create the damage in the population or the structures upon exposure.
Just focus on the house. We're talking about now not just vulnerability of the people, but we're talking about, I don't see any people here, I just see houses. So what is the different? So which house is the most vulnerable?
Probably the furthest left one, the one located in the flood zone and with the poor foundation.
Yeah, exactly. So here, these 2 houses, thank you, Winston. So these 2 houses have the same exposure because they're exposed to the flood zone in the same way. The location is the same, but the vulnerability is more related to the condition of the houses, to the how well the houses are built, what materials were used, and so on. So between these 2 houses, if they have the same exposure, but the most vulnerable is of course the one with poor foundation. Oh, sorry, with poor foundation compared to the one with a concrete foundation. So I just want to skip here to this part. Just want to skip to this part because I just want to show you, before the end of this lecture, how we measure in practice the vulnerability. And as I said before, is identifying deprivations and exclusions of specific target populations. And as I said also before, when I measure vulnerability, I'm also able to then prioritize which communities, for example, among the communities that are struck by the disasters, which communities require special attention, or which population groups require special attention. And so I need to reduce the impact of hazards. I need to build capacity to cope with hazards, because if I understand exactly what factors make those individuals more vulnerable to the effects of the disaster, I might be able to intervene and cope with the mechanisms that underlying the impact of disasters. And there are different models, different frameworks. You don't have to learn these, but just memorize the fact that we as disaster research, when we need to assess vulnerability, we refer back to different disaster frameworks. You just have to choose one and follow the framework. So for example, this is one framework to assess the disaster risk of a person. As I said before, you need to take into account, you remember the mathematical formula, you need to take into account the probability and the severity of the hazard, you need to take into account the exposure, the vulnerability in all its components, and the capacity and measures. So what is the capacity that the population or the individual can put in place to respond to the effects, to the impacts of disasters? This is another one. It gets more complicated, but it's always the same thing. Root causes, dynamic pressures, unsafe conditions, and another mathematical formula with the hazard. But what I just want to focus on is the BBC conceptual framework. Again, you don't have to learn it by heart. I didn't learn it by heart, but what I use it for is that it's pretty interesting because it takes into account all the spheres, the areas of vulnerability that I'm interested in. And so to perform a vulnerability assessment, you need to consider exposure, the susceptible elements, coping capacities, and not just, as I said before, the deficiencies, but also the coping capacity. And the focus here is on vulnerability reduction, coping capacities in all aspects, as you can see. So in the physical aspects, economic, social, and environmental. So I want to finish here with the case study, but I really want you to be a little interactive, and then I'm going to leave you in peace, because this is going to help you understand the concept of vulnerability of a community, of individuals, in a real life scenario. So the case study is from this publication from Bergman in Disaster Preparedness 2016, if I remember correctly. It's basically a publication that draws from the Indian Ocean tsunami, as you might remember, in 2004. And our task is to measure the vulnerabilities of two communities in Sri Lanka. One is in Batticaloa, and the other one is in Galle. And we are part of an NGO that is deployed in the area in the aftermath of the disaster. So our mandate is to identify in the aftermath of disaster. So we were sent just a couple of days after the disaster, because this NGO wants us to find out who the most vulnerable communities in these two communities are. And we're going to use, again, the conceptual framework to understand risk and vulnerability, because we need to consider, again, the vulnerability factor, but also the coping strategies, because our mandate is to identify who the most vulnerable is, to then be able to implement interventions that are whose objective is to reduce the vulnerability of these communities. Of course, this is our mandate, this is our objective. So then my question to you is, in terms of environmental, physical, and economic, again, this is the concept, this is the context here where we are, okay? How would you then assess vulnerability in terms of environmental, physical, social, and economic aspects? Can someone venture an answer? Guys?
So we should use the conceptual framework that. Oh, okay, got it. Oh,
yeah. What I want you to do is just forget the framework for 1 second.
Okay.
Just focus on, just answer the question, how would I assess if I were in this situation? How would I assess the vulnerability? So who the most vulnerable is in terms of the environmental characteristics of these situation, the physical, social characteristics of the individuals living there, and the economic. Who is the most vulnerable within these characteristics? I'll give you a hint, you know? If this is the context where we're living, who do you think bore the worst consequences of a disaster? Let's not consider these three characteristics, but just off the top of your head, who do you think the most vulnerable is?
I suppose considering it's a tsunami, right? So perhaps those, well, I think both those Sri Lankan cities were near the coast, but those particularly directly on the coastline or living on low-lying houses, or those perhaps most predisposed to certain, I don't know, vector-borne diseases that would be most present in the water, could be most at risk, most vulnerable, so to speak.
Yeah, good point. Let's hear from Enas.
Yes, I agree with what he said. The people who are living near the disaster, like maybe in the coast, and also maybe if their houses or the infrastructure is really poor, it will also make them more vulnerable to the collapse. And yeah.
Very good, thank you. Natalie?
Yeah, I think what I'm gonna say is similar. I just wanted to say the people who became homeless from the disaster are maybe most vulnerable.
Yes, very good. And we have here Rabbe.
Yes, so I think the people who are already suffering from some sort of ailment or malnutrition, or children, pregnant women, for example, those who actually need an ample supply of fresh and clean water, because the tsunami does disrupt the natural water flora. So those people.
Yeah, absolutely, very good. So I mean, all your answers could be easily categorized according to this scheme. And as I mentioned before, this is just one way to categorize all your answers, all the work that we are mandated to do. So what I'm saying is, when you find yourself in this situation, it doesn't matter, if you are a PhD physician, if you're a hospital doctor, if you're an NGO, if you're part of the international organization, this is exactly what everyone is doing, assessing the vulnerability elements according to different categories. And this is the framework that I most frequently use. But as I said, there are many, many, many. And as I said, you don't need a framework to understand how to assess who the most vulnerable community or individuals are. And so, for example, some of them you already mentioned. So location of the household. It is clear, as some of you had said, that if your house is near the coastal line, it's more prone to be affected by the disaster. Or the structure of the household is again another aspect of vulnerability that contributes to increasing vulnerability. Or again, some of you had said it already, the housing conditions after the tsunami. People that are homeless, of course, they are going to be more vulnerable than others. Age is a physical important aspect. It is clear that elderly people or people with reduced mobility are more prone to negative effects of disasters. Gender, I think Rabbe mentioned the pregnancy, the pregnancy factor, or the disability factor, or the education. And of course, poverty and disaster-related direct loss of possessions are, of course, economic factors that need to be taken into account, because they are directly linked to a vulnerability level. And what about coping strategies? What do you think the coping strategies can be? As in the coping strategies that the communities might put in place, might implement to resist to the effects of the disaster that had just happened. I mean, this is pretty easy to think, because if these are the vulnerable factors, for example, housing conditions and impact of tsunami, if I'm homeless, what is a coping strategy that I might put in place? Natalie, please.
Okay. I think maybe access to shelters and
Yeah, or even yeah,
and access, like maybe if someone is how do I say it? If they're a registered citizen of the country, that's a coping strategy. Otherwise, if someone is an immigrant and they don't have access to these coping strategies, that
yeah, absolutely. But what about something easier than what you've just said? I mean, that was brilliant. That was completely right. I was thinking of something more low level, more basic.
Maybe primary healthcare access and
yeah, but even more basic than that. What would you do if you lost a house just after a disaster? What I would do would be to call, if it's possible, to call. I would be just going to my family or to my social network of friends, of people, But then again, this resonates with what you were saying. For example, being a migrant or having arrived to the place recently, so having no social network or no social connection, this is a factor that hinders or increases vulnerability. And so coping strategy is, again, having people who can support you. And I guess also knowing that, or being prepared for disasters, and knowing that that part of the world is prone to tsunamis would then, for example, have you build a house that is made of concrete foundations, even if it's on the coastal part of the country, and having the so-called a response plan, so the ability to be prepared and be quick to respond to the effects of disaster. You know, having experienced the earthquake and knowing that after an earthquake you can get a tsunami, and so having that piece of knowledge would then be helpful to have your coping strategies be implemented. You know what I mean? So knowing what to do is always, and so being informed is always the best coping strategy. So again, as coping strategies, I wrote individual household members' knowledge of tsunami and coastal hazards before disasters, as a formal, having formal and informal social networks, access to information, so radio, for example, and also having money, having a financial support from organizations, or not being poor is, of course, a coping strategy. I'm not going to focus on interventions now because I have another slide, because here is what I want to ask you. Now we are trying to, so these were the factors that would then contribute to make individuals more or less vulnerable. Now I want to measure quantitatively the physical vulnerability of people. So I'm an NGO representative. I am in the middle of that chaos that you've just seen in the photos, and the NGO has asked me, please go and assess who the most vulnerable is from a physical point of view. So from a physical point of view, who was impacted the most by the tsunami? And they just give me this and this, which is paper. Okay, so nothing more than that. What indicator in that context here can I use to assess physical vulnerability? There are no wrong answers, please. I'm not here to judge or evaluate you. I'm just here because I want you to use your brain. What can I use? What can I measure in that context here to understand who was the most vulnerable in terms of physical aspects? So when I'm talking about physical, I'm talking about health. I'm talking about people, health-related consequences of a disaster.
Maybe people who are admitted to the hospital, or
say again?
The number of people that are admitted to the hospital.
It's a very good answer, very good answer. But again, very basic. I'm here. I still haven't gotten to the hospital yet. But this is a brilliant answer, but this is at a second step.
Maybe just
and in us, I'm not talking about houses now, or maybe that was an answer from before. I'm talking about people. I'm talking about individuals, and I want to see the health-related consequences of the disasters. What can I use? What can I count? I'm helping you a lot now. Someone raised their hands.
Yes.
Where are you guys? Rabe. Yes, please.
So the number of people who have access to fresh water supply and proper food.
I mean, that's a very good answer, but that's a very specific. We just want to see, first of all, we just want to see who suffered the most immediately. Just so that the disaster had just happened 3 days ago. I want to see, or just 1 hour ago or whatever, I want to see who suffered the most.
Can we use the triage, like the theme, the triage theme? Can we use like who are the red patients and who are the yellow patients, and then count those?
Count what? Yeah.
The triage. Don't we
Okay,
do?
but triage is something that you do. You know, you can't count triage. Triage is just selecting, you know, who.
Yeah, I mean, count who are the red marked patients and count who are the like yellow marked patients.
Okay, close. That's a good answer, but that's not what I'm looking for. But it's proper. Winston.
I'm wondering if this is what you're looking for. Perhaps in different demographics in this area, their morbidity or mortality rates.
Yes, that's exactly what I meant. Mortality even before morbidity. So the first thing that I would then need to do is who died because of this tsunami. So who died, and second of all, who is missing? What can this information give you? So if you count dead and missing and disaggregate them by gender. Wait. Laura, Kritika, people that have never spoken, can you please venture an answer here? Can you please comment on the graph, on the chart? Okay. Laura, okay, Natalie, someone? Zekin, okay, Laura, please venture an answer. There are many other charts, so you all get the chance to talk. Please, Natalie.
Yeah, I thought there's someone that's raising their hand, so okay, I'll comment just.
Don't worry. Yeah, go ahead.
So I think it just gives us like what gender is more vulnerable in this particular disaster.
Yeah, exactly. And can you comment the chart? Just explain it to me if I didn't understand the chart.
Okay, so in Galilee City, the females, in both cities, the females outnumber the male patients.
Exactly. So what implications or what hypotheses can you draw just by looking at this very simple graph?
Regarding the physical vulnerability, maybe if females didn't have the physical structure like to swim and survive, so they were.
Yeah, and then you can venture hypotheses on why that is. That women are more vulnerable, physically vulnerable, because they died more frequently than men, and because they're missing, so they're probably, you know, drowned in the tsunami as a tsunami hit. So what can also be another explanation of why females were more hit? I'm going to ask that to, I think someone had raised a hand. I think it was Zekin.
I'm not too sure, but could also be because there were more females initially in the population.
Say it again, please. Say it again.
It could be that there were more females initially in the population as well.
There's a background noise, so I can't hear you properly.
She said that initially in the population, the females are more, like their number is more.
No, because this graph was done in terms of like by adjusting it, and so the numbers were adjusted by the proportion of the population. So this cannot be the explanation. Another explanation is that is more linked to what I think Winston was saying about the fact that the most vulnerable people were those living on the coastal lines, near the sea. It can also be that the females were at home because they were working at home, and men were went to work away from the coastal line. As I said, just by looking simply at mortality data, we can venture hypotheses on why, on who the most vulnerable after the tsunami was. And another thing that I can then further disaggregate this data is, can you think of another way? So you have this, yeah? And now I'm asking you, okay, is there another factor that you can disaggregate it by this data?
Perhaps by demographic. I don't know, like different minority groups, for example, in this area might be differently affected, and perhaps some of them are more, I don't know, restrictive or more. It just happened to be that women were more affected in those certain minority groups, and therefore
I would say
results.
Yeah, thank you for contribution. So you were right when you said demographics, and you're right when you say let's do it by, I don't know, minority and stuff. But there's another easier way to disaggregate it, very easy. And yeah, Natalie, you're right. Age. Natalie has just written age in the chat. So yeah, age distribution of these numbers here. So this chart can be further disaggregated according to the age group. And what can you see here in this age group, in this chart? So what you can see here is that the absolute number of people killed in the age group is, for people from 0 to 10 years of age, this is the greater. So the relative number is greater. But the relative number, if I then talk about the relative mortality in the age group, as you can see, the elderly people, even though the absolute number was 11, the relative number is 12, is 11%, because the relative mortality in the age group is greater. So by disaggregating through age group, according to age distribution, you will see that the two most vulnerable groups of women and men were at the extreme sides of the age groups. So young people, infants, and elderly people. And another reason for the reasons for this age gap can be because these were the people, like, for example, I'm thinking, just by looking at this chart graph, is that the elderly and the newborns were the most affected, probably because what I was saying before, that they were at home when mothers and fathers were at work. And so elderly people, like grandmothers and grandfathers, were taking care of the babies. But this is, again, these are just crude data, and they're not talking to me. They're just giving me hints and hypotheses on what could be the reason for what I am counting. And of course, part of the work of this NGO representative of this case study will be then to prove the truth of this data, whether these data are true or not, or the explanations that I'm giving are true or not. Another thing that I can do is to search for indicators for environmental vulnerability, focusing on household, for example, on the structure of household. And what you can assess from this graph is Enas, would you want to, or Zekin, do you want to comment on this? Or maybe she didn't have a microphone. Rabe? As you can see here from this chart, the author of this publication set a buffer zone, like a limit of 100 meters from the sea, and he counted within and over this limit of 100 meters. He counted the degree of damage to the structures of the household, dividing them in 5 different categories. So those houses that were damaged totally, those houses that were that couldn't be used, damage that could be used partially, or just houses with minor damages or no damages at all. And I think what's interesting in this graph is that the impact of the tsunami could also be seen. See here, this is outside of 100 meters from the sea, so that the effect of the tsunami in damaging totally the structure of the households could be seen also in outside of 100 meters of the location of the tsunami, meaning that the effects of the tsunami could also be seen outside the 100-meter zone. And this assesses for the environmental vulnerability. And why is this important? Because if I then integrate this information, like loss and damage suffered by household. So is this household damaged completely or not damaged at all? And then I assess it with the income, for example, that that household had before and after the tsunami. I can also derive the time of a household to recover from property damage, for example, 6 months after the disaster itself. And here you can see, I mean, I don't think you can probably read properly, but here, for example, you can see that those people who needed more time to recover from property damage were fishermen and housekeepers, meaning that their houses, of course, they were fishermen, so they were likely to have the house very close to the sea, and their income was definitely lower than that of fish seller or small-scale business or tailoring. And so by computing and integrating these 2 different indicators, you will then be able to extract the information of who was the most the least, in this case, vulnerable and the most able to cope with the damage, with the property damage. And why is this important? Sorry, why is this important? Because if I then do a thorough vulnerability assessment, and I know then that the women, elderly women, newborns were the most vulnerable categories, or fishermen and housekeepers, I can then focus all my interventions on these vulnerable populations. For example, focusing on preparedness strategies for women, for elderly, for younger populations, or for example, focusing on disseminating preparedness information, awareness, and knowledge among the populations in our area. I will then go to them and say, you know how you need to build your houses for the next tsunami that will happen in who knows how many years. You know that even though you live 100 meters away from the coastal line, you need to build a house that is whose foundation is made of concrete. And economic vulnerabilities, I need to then boost and regulate financial support from all the organizations going to those specific vulnerable populations that are most vulnerable among them all. Just one last, last 2 minutes. I just want to show you, just for your information, there's another way to assess vulnerability, and this is an interesting tool that the International Federation of Red Cross, so the IFRC, is a very interesting tool. You can download it from the internet. Is a practical tool to assess vulnerability, and what you basically will do, there are different steps. So you start from an hazard and exposure assessment, you do the vulnerability and capacity assessment, and these are all the sort of steps that you need to cover. You need to cover, sorry, to then assess the vulnerability and capacity. You will then come up with, so identify the hazard. You will then be able to assess the vulnerability, as you can see here, the impact, the vulnerability aspects. And in the end, you will, you assess here the capacities. And in the end, you will come up with something that's similar to the mathematical formula that I showed you before. And with this score, you will integrate exposure and vulnerability with coping capacity, coming up with a score that can be high, C, if the exposure per vulnerability is high and the coping capacity is low. You, of course, have a very high risk level. And this is a practical way that, for example, the international NGO of IFRC uses to assess vulnerability. And here what it's saying is that the risk level is the highest when the exposure and vulnerability are high and the capacity is low. And this was another way to assess vulnerability. Why am I doing that? Of course, again, to plan interventions, because the interventions can be planned according to the most vulnerable categories, to report and share, to mobilize resources, but also to track progress, because you can repeat the same vulnerability assessment in, let's say, 6 months, 1 year after the disaster, and see if and what has changed. This was the end of the lecture. Here, of course, I'm going to share with you the presentation, and here are very interesting, according to me, very interesting material to the topic primary healthcare and vulnerability and disasters. I will, thank you for your participation, even though it wasn't the most active and interactive of the participation, or for some of you. And I will see you in... say it again?
No.
I couldn't hear you, sorry.
No, I just opened the mic by mistake. I was talking to my brother. Sorry.
Okay. Say hi to your brother. So, I'll see you in let's say 5 minutes, because we're gonna give, together with my colleague Andrea, we're gonna give another lecture on COVID-19 and training experiences. Just a very brief talk on COVID-19 lectures. So I'll see you in 5 minutes, I guess. Just stay connected.
So I'm sorry, I didn't hear you quite well. We will start at 3:30 or start after 5 minutes?
Yeah, you're right. I just need to double check with Stefania because she's the big boss.
Okay, but the calendar that we have states that we're gonna start at 3:30.
Okay, well then 3:30 it is. Let's meet at 3:30 then.
Okay.
Okay.
See you then. Bye.
Alessandro?
Steffi.
Alessandro?
Yes.
Hi, sorry, I was absent-minded, but what's what's the deal?
No big problems. So we'll start back at 3:30 with Andrea for the next session. Okay.
Okay. Great.
Okay. See you in a bit.
Thank you so much. Bye, Alessandro.
Bye bye. So guys, welcome back. We're gonna start in 1 minute. Okay. So can you guys hear me?
Yes.
Thank you.
Yes, we can hear you.
Cool, thank you. So from primary care and vulnerability to training, and I'm gonna share this lecture with a colleague of mine. Andrea is gonna introduce himself later. The topic of today's presentation is training and disaster management, our perspective, the perspective of our research and training institute during COVID-19 pandemic. I'm gonna give you a brief overview of the just-in-time training initiatives that we performed during COVID-19 in urban field hospital, in a tertiary referral hospital in northern Italy, but also remotely with a training of trainers online approach, and also in some humanitarian settings. And Andrea and I are going to share some of the initiatives and experiences that we took part in during COVID. I'm not going to say anything new when I say that the pandemic has threatened health systems globally. It required extraordinary international response, and it forced all of us to adapt everything basically. But those of us who care about training in disaster medicine, especially adapted their training programs, usually residential, usually in person, involving large real life scenarios. And we were catapulted in a new different scenario of online training. The response to the pandemic included the effective education and training of healthcare workers. This was like this globally. And globally, healthcare workers had to attain several operations level public health skills, and most of them were not familiar with public health emergencies, and they were lacking basic experience and knowledge of disaster medicine. Just a brief overview of what was COVID for us here in Italy. Probably you already know that it has been one of the most affected countries, especially at the beginning of 2020, especially during the first wave. And up until now, 18 million of infected people and over 170,000 deaths. Many health workers were recruited from other departments, and so they had been working outside of their field of expertise. They had never worked with a PPE. So the risk of secondary infection, especially at the beginning of the pandemic, was very high. So we stepped in as a research and training institute in February 2020. We developed a just-in-time training interventions to equip healthcare workers with basic competencies in disaster-specific information, tasks, skills, and knowledge just before the deployment to a disaster-stricken area. And that is exactly what just-in-time training means. And the training initiative, as I said, were held both in person, both in hospitals and in field hospitals, but also remotely online, both in Italy and in some African countries. starting with the first one, we delivered an online just-in-time training in 6 different African countries. You can see them on the map, collaborating with an international NGO called Doctors with Africa, funded by the USAID, international NGO USAID. And as I said, we delivered a whole program of 15 lectures on our learning platform, equipped with videos, documents, further readings. And the beauty of it all was the content that was not just related on health, but it was a multidisciplinary content. There was some introduction on disaster management, clinical information on COVID, mental health, gender in disasters was also covered, as well as some practical information on how to don and doff and how to work in resource-constrained environments. And the program, as I said, was very wide and broad, and provided the NGO staff with a common background on disaster medicine, how to proficiently and safely work in low resource settings, how to understand the working principles and standard procedures at the hospital, how to accurately apply and safely remove PPE, and how to understand basic principle of disaster medicine applied to the COVID pandemic in a limited resource setting. And as you can imagine, most of the healthcare workers had never studied anything related to disaster medicine or global health in medical or nursing schools. In delivering such a course in an online manner had, of course, pros and cons. And I personally found that the most important pros were that the course was quick and cheap, both for those who organized it and for those who had attended it. It was comprehensive, it was practical because it was pre-registered and pre-recorded, and it was interesting because, you know, everyone could access this the whole package whenever they wanted at home, and it was very much appreciated. A big con of it all was the fact that you know, no one of the speaker has English as a first language, so it was possibly difficult for NGO workers in Africa to follow such technical terms in being said by non-native speakers, and it wasn't interactive, so it was pretty you know, monotonous, the fact that the lectures were just frontal lectures were just delivered, and also lecturers from Europe didn't know exactly the context of the hospitals that where they were delivering the course to the NGO workers. Another interesting initiative that we performed was training in an urban field hospital. You have to imagine this wasn't the first wave, this was already the second wave in November 2020. In Italy, it was the beginning of our second wave. The health systems were overburdened, and there were public health authorities trying to find ways to ease the strain off of the health system, like trying to re-engineer hospital services, expanding in-hospital stay capacities, closing dispensable services, and so on. And so one initiative was building and opening this field hospital called Valentino in the northern part of Italy, in Turin, which is one of the biggest cities in the northern part of Italy. And our research center was appointed for the elaboration of guidelines and the training initiatives. So these are some specific technical information, and this was the map of the hospital. Everything was on point in terms of technical information, of logistics. It just took 11 days to build the whole thing. And as I said, Krimedim wrote the guidelines, and you have to imagine that this hospital was a low intensity hospital with a low level of medical complexity. We wrote the guidelines in a multidisciplinary team with ER doctors, anesthesiologists, infective disease specialists, disaster experts, and so on. And the human resources that we had to train were provided by the research hospital. And you have to imagine that our the human resources were constituted by young and very motivated, actually, medical doctors and graduated nurses, and also doctors coming from other specialties were pretty much non-clinical ones, so like pathologists. And these are a couple of pictures from the hospital. And as I said, it was a low intensity, so were patients recovering from severe forms of COVID-19, but yet not ready for discharge. There was a permanent nursing presence, but lower medical staffing levels required. But there was, of course, a rapid response team in case of emergency. So what we did, we delivered a training program giving guidance in disaster medicine, a standard precautions on infection and prevention control, how to don and doff PPEs, staff behavior in outbreak settings, of course, some clinical info on symptoms, diagnosis, and treatment of COVID. How do you do triage in such a setting? What are the admission and discharge criteria of the patients? And also some information on logistics. So how do you turn on, for example, the oxygen concentrator, or where do you get the saturation monitor? And also, a very other interesting part was the simulation, which I believe was the most effective and rewarding part of the training. There was a comprehensive scenario. So we started off at the very entrance of the hospital with the triage and medical examination. Then we moved on to the ward round. Where do you place the patients? Where are the beds? Where are the tents? So what happens in case of an emergency, like resuscitation, or how do you alert the emergency team? Where is the emergency team? And we introduced also an element of surprise. That was the idea of our coordinator, Luca, who introduced this sort of called disaster in the disaster, which I really liked. So what happens if a bomb explodes, or someone wants to break into the field hospital? So how do you behave? What procedure do you follow? And many elements could be assessed through this simulation. Like, for example, no one knew. Remember, these were very motivated yet young medical doctors and nurses. So the workflow was tested through this simulation, and all the healthcare professionals working there knew where the phones were, where the computers were, how to turn on the computer, how to turn on the oxygen concentrator, all these things that seem pretty dull and stupid, but trust me, during the daily work, these are things that you probably should want to know. And why was it useful? Again, because it tested the workflow, it improved the communication to simulate as though a real life scenario, and also helped in identifying who was who. Like, for example, no one knew I was the I don't know, anesthetist or the emergency physician, or how should I know that that was the logistician or another important profile? So through this simulation, everyone identified immediately, okay, these are the anesthetists, these are the emergency team, these are the nurses, and it helped the facilitating the process. And also we realized that there were some missing parts. Like, for example, no one had thought about the telephone numbers. So through the simulation, we knew that there were some points that needed still to be tackled. And why was it this useful? Because, as I said, it was an interesting example of a model of low intensity care during COVID in an urban setting in the midst of a pandemic. It was specific to COVID-19, but it's generalizable to other sorts of disasters, other hazards, other situations. It helped us understand that the research institution or the training institution in that case was facilitating the role because it had the expertise in disaster medicine, and the simulation, as I said before, made everything run smoothly, facilitated the role between and the processes between different stakeholders with no or little experience in disaster medicine. In conclusion, from my part, at least the pandemic's characteristics brought that a high number of healthcare workers needed to be trained and quickly trained in disaster medicine. They were lacking basic knowledge of disaster medicine. They needed to be trained. The greatest number of people needed to be trained and also needed to be protected from the high risk of exposure. So training was of fundamental importance in that case. And also we needed to adapt our training programs through different modalities to the ongoing pandemic and its related restrictions. And with the objective of delivering effective content, to increase retention and to share knowledge. The result is that we use different learning and teaching methods, but we reached the objective. And as the future steps, we will broaden our knowledge and expertise and share it, as we're doing it right now, with other professionals, like, as I said at the beginning of my first presentations, primary care professionals or community members who have been historically neglected from disaster management courses and simulations. So maybe that could be an interesting way forward. Thank you so much, and I'll leave you with Andrea, my colleague.
Thank you, Alessandro. Thank you a lot. And good afternoon to everyone. First of all, nice to meet you. I'm very happy to see also this year the TDMT project that actually I coordinated for some years in the past. So I'm happy that a lot of medical students worldwide are interested in this field that is disaster medicine. And unfortunately, as I think we repeated a lot, and as you know, the pandemic told us and told all the healthcare professionals that we need to focus more and to boost the training in disaster medicine. So Alessandro showed you some approaches to the just-in-time trainings. Now I would like to present you two different approaches we had during the pandemic. But why focusing so much on the pandemic? Well, because in general, it's easy to work in another country. I mean, it's easy to go to Africa to fight Ebola, or to go to another country to try to cooperate to solve a problem. But where the disaster, where the pandemic is here, it's very difficult and we have to adapt. So I share you my screen and we start with a little intervention delivered in Novara, but that contains a lot of useful take-home messages. Okay, you should be able to see my screen, right?
Yes, I mean,
good.
You can see.
Yes, so, this was a very small intervention performed in our city, Novara, where is placed Crimedim. At the beginning of the pandemic, our research center was asked to cooperate in the local hospital to provide a basic training. Remember, we were at the beginning of the pandemic, so we didn't know a lot. We didn't have all the scientific knowledge that we built in the next month, but we had to adapt the previous information, knowledge, and experience to deliver something to the health professional. And this is the settings. The Novaras Hospital is the second hospital in the Piedmont region, in the north of Italy, for bed numbers. It's a very huge hospital that is organized in different pavilions and is also one of the major hubs for COVID patients, with more than 200 beds and dozens of healthcare workers. The majority of these healthcare workers had to change their roles, tasks, and habits. But there was also another problem that Novaras Hospital in general delivers different non-deferrable procedures, for example, deliveries or emergency interventions that, of course, have been maintained. Of course, Novaras Hospital had a disaster plan, a general disaster plan according to the Italian law, but it was not enough. It was not enough because organization is not only is not the only issue, but different emerging needs were discovered in the first days and in the first weeks of the pandemic, both for the hospitals and for the workers. Remember, professional doctors, nurses, technicians that used to work in a specific way for years, for decades, had to change their habits in some hours. And that is disrupting, that is not easy for all the professionals. There is not the perfect hospital disaster preparedness plan that works in the right way. So from one side, hospital needed to ensure, of course, the quality and quantity of the services, but also facing the problem of the infection. So reducing the number of infections and containing the outbreak, especially among workers, and also to reduce absenteeism. But absenteeism caused by a specific issue that was the workers' behavior. I mean, at the beginning of the pandemic, all the doctors, all the healthcare workers were frightened. They needed to feel safe, to feel confident in an hostile environment, but also to feeling part of the system. And in this situation, a written plan is not enough. You have to give like a human approach, a human contribution to help the professionals to feel safe and to work in the proper way. But in addition, they also needed to learn to use the protective equipment and how to move inside the new environment. And also in this situation, actually, this was the first just-in-time course for COVID-19. We used this approach to adapt the previous cremating knowledge to the specific context. Just in time, why? Because courses were performed in the late afternoon, all the days for some week to train all the personnel during the first phases of the pandemic. So they worked in the morning and in the afternoon, and they went to the course in the late afternoon. So it was continuous and during operation. It has different characteristics. It was quick, not a lot of hours, some hours, 2 or 3 hours, easy both to understand, to write the content and to deliver. Essential. We didn't need to teach all the theory and all the content of disaster medicine. I mean, it could be great to teach all the aspects, but it was not possible. It was also practical to tell and to teach how to use the personal protective equipment, and it had also to fit both needs, the organization and workers' ones. We had 3 main objectives: to enhance the personal awareness, preparation, and the resilience of the professionals, but also to address specific topics related to the disaster management and to the pandemic, but also to instill confidence about COVID, about PPE, and about working with new procedures and within new environment. It was 4 hours training every evening or late afternoon for 3 weeks, with 3 major topics: introduction to COVID, policy and procedures, to PPE, and of principle of disaster medicine and public health emergencies. So, I mean, we wrote a different feature, characteristic, objective of the course. Was everything perfect? Of course not. We learned a lot after this course. We learned that during the session, the participant had trouble listing all the ways of protecting because they were not prepared before the COVID-19 pandemic to protect themselves. They had also difficulties in understanding WHO recommendation because Novara's healthcare professionals were not used to read, to use, to study international documents. And also they were unfamiliar with the response mechanism in Italy and in our regions. But at the beginning, I said that the big problem was that COVID-19 was here during the training, and recounting experiences about the 2014 Ebola outbreak was useful to face them to the pandemic and to better understand the basic importance of infection prevention and control. And also another important point is this one, because trainers spent a lot of time after the session to respond to difficulties, to questions, to curiosities. And this was very important to establish the human connection and to not only deliver knowledge, but to make them more confident about procedures and about treating COVID-19 patients. So the first key learning was that is crucially important to answer all the questions. Doesn't matter if the session is too long, doesn't matter how much time do we need, but it's important to make participants confident with the trainers. But we had also to face other problems. During the trainings, we used some PPEs, but in the hospitals, there were different PPEs supplies. So this was an issue. And we also understood that all the trainers, to feel confident and to feel safe within PPEs, had to try at least once to use them. And we also discovered that trainees had a huge lack of experience with large-scale public health emergencies, and the module of principles of disaster medicine was essential to put them in the right perspective. Also, in this last module, we used the discussion-based exercise on trainers' experience, for example, during Ebola or during Haiti earthquake, to put them in the right perspective. So, what are the take-home messages about this first just-in-time course? It's important to focus not only on procedures, rules, clinical features, plans, responsibilities. Remember that healthcare workers are humans, and if we want to make them confident in working in an hostile environment, we have to listen to them and to bring them some examples, to raise their awareness about how disaster medicine works and about which is their role in this specific context. And remember to keep it simple. We don't need to give a degree to build a very long and a very complex course, but only to face a sudden situation. So remember to teach, to tell, and to discuss about only what they need in terms of knowledge, but also in terms of attitude. And also remember that just-in-time training is like a patch. It's not the definitive solution. It's a patch on a system that in the past didn't provide the correct base of knowledge in disaster medicine and in disaster response. So during the COVID-19, we used with success the just-in-time approach, but this should not be considered the definitive, but only a patch. So the first presentation, this one, was to present you how to deliver a just-in-time training face-to-face in a structure, in an hospital to healthcare workers. But the big limitation of this approach is that you can reach only a limited number of people, of course, only Novara's professionals. So together with QAM, similarly to the international project, we delivered a just-in-time training online course from some point of view similar to the one presented by Alessandro, but different in the basis. So since the beginning of the pandemic, we promoted this dissemination of knowledge through Italian healthcare professionals, yes, using an online course, but also applying a training of trainers approach. That is the same strategy used in the TDMT. But why? I remember at the beginning that there were a lot of information, of studies, of also Facebook groups of professionals where doctors, nurses wrote a lot of different things, fears, and uncertainties. So we are in the digital era, and the general population, but in particular healthcare workers, were overloaded by COVID information that was not always reliable, but often confused. So it's not yet, it's a problem, but it's not so huge if you are a simple citizen and you don't have to take a decision based on this information. But if you're a doctor, if you're a healthcare professional, of course it matters a lot because you have to take different decisions based on the COVID data and information you have. And of course, if your routinary work is saving lives, this is critical. We searched in the scientific literature and we found a lot of publication, like a surge of publication, because everyone wanted to say his or her opinion, because there were a lot of studies, and it was difficult, sometimes with the difficulty to keep in mind the basis of the response. So, as you learned in the past lectures, disaster response is based on the 4 S: the system, the structure, the staff, and last but not least, the staff, the people, the persons that work within the system. So the main concept that is that we were actually in a pandemic. That's a disaster. It's defined by definition a disaster. So we need a specific training in disaster medicine. Remember the surge of information, the surge of science about COVID-19. That's good because it provided us a lot of information. but the number of studies, the number of resources about basic disaster medicine knowledge was very small. Knowledge about triage, resource management, and ethical dilemmas that are like a transversal topic through different disasters. The basic concepts are the same in pandemics, but also in floods, in earthquake, and in other catastrophes. With another huge problem, that disaster medicine and global health, but also the most basic knowledge about these two topics are not included in the Italian medical school curricula. So we had a huge number of professionals that never heard about disaster medicine. So they were in a pandemic without the minimum basis. So the idea with Dr. with Africa Kuam, and this idea was taught before the international course, was to create a simple, common, and shared curriculum for health professionals to reach the maximum number of them all across Italy, with the objective of spreading basic but innovative and evidence-based knowledge. So if in the Novara settings, the objective was to train all the healthcare professionals working in these specific hospitals, here we cannot directly face all the participants as CRIMEDIN, because we are a limited number of people, and the great objective was to reach all Italian professionals. And our didactic structure followed a three-step approach. First of all, awareness. As I told, the majority of Italian healthcare professionals never heard about disaster medicine. To put them in the right perspective and to help them to have the right mentality and approach about the COVID-19 response. Only after building these first two layers, then we put the bricks of knowledge on them. And we structured our curriculum on 6 different topics. Introduction to disaster medicine and public health emergencies with basic principles, and on them put the specific knowledge like clinical and epidemiological aspects, procedures, policies, infections, and lessons learned. More important, this course was delivered to different Italian professionals working in different contexts, from the pre-hospital scene to the hospital settings, and all across Italy. So during the course, we pushed a lot to make a network between them to share their experience about routinary work with COVID patients. Remember that we are talking about the beginning of the pandemic. And I already spoiled it to you, but to reach the greatest possible number of people, we use the training of trainers approach. The same used in the TDMT, used in disaster SISM, and in other training projects. So we, as CRIMEDIN, we were 3-4 trainers, and we trained like a dozen of peer trainers. Each of them delivered different basic courses based on an online platform, including videos, including lectures, documents, but also including this moment in a video call, in a video conference, where the peer trainers led a discussion through the professional to share experience and to put them in the right perspective of disaster medicine. So 6 of us trained 49 peer trainers, and in total they trained different dozens of participants from 17 different organizations like hospitals or clinics. It was also a multi-professional course with only 1 out of 4 of physicians, but also nurses, health assistants, and other professionals. So it was not only for the clinical part, but it was for everyone working in the health sector. The majority of them worked in a university hospital, some of them from a public one, but we had also participants from the territorial health services, general practitioners, and from retirement homes. And this was very useful to allow them to share their vision, their perspective of the pandemic. As you can imagine, the perspective from the general practitioner is completely different from the university hospital one. And almost in Italy, we have the problem that the sectors are not very well connected between each other. And this type of approach was very helpful to strengthen the connections. Of course, this is not a new challenge. The e-learning, the live video conferences existed before COVID-19, but this approach allowed us to define a specific learning path for all the courses, to make them reliable and also scalable, that can be delivered to different number of people. And it was very easy to implement and also cost effective. This was, of course, designed specifically for COVID-19. I hope that our presentation can help you in designing your courses. Personally, I hope that you won't have to use the just-in-time approach, because it means that you are in a disaster. But the different perspective can help you to focus not only on the learning content, but also to the other aspects, like the human relationship, the connection between different health sectors, the different skills, the non-technical skills in delivering trainings that have the same importance of the content. Thank you.
Guys, are there any questions to either Andrea or myself? So if there are
no, thank you.
Thank you, guys.
Thank you too. Thank you too.
So if there are no further questions, I guess we can wrap up. And we'll see you tomorrow for the next session.
Thank you, guys. So see you tomorrow. Also from me, tomorrow we are going to have, as you know, the CBRN session with an interactive exercise. So if in the meantime you have new question about today's lecture, simply ask me tomorrow.
Cool. Okay. Cool. Good. Then see you tomorrow then.
See you. Thank you. See you tomorrow. Bye.
Bye-bye, guys.
Ciao, Ale. Bye, bye, everyone.
Bye.